Welcome back, everyone, to San Diego Healthcare Innovation Summit Virtual. We're so pleased you could rejoin us. We've got a fantastic panel of great experts and industry leaders here. I'm going to actually have each introduce her or himself. And we are going to talk about population health, leveraging data and analytics for population health. Really, I couldn't gather together a better group of folks. So I'm literally just going to go around the circle here. As I like to say, we're in a Brady Bunch world. We're all in little boxes with each other. So I'm going to start with Dr. Amy Sida Patel. Dr. Sida Patel, why don't you introduce yourself, your title, role, and your connection to the subject.
Thank you. It's a pleasure to be with all of you today. I'm Amy Sida Patel, and I'm a Chief Medical Information Officer of Population Health at UC San Diego Health. I'm clinical professor in the Department of Medicine in the Division of Biomedical Informatics, and I'm also the interim division chief for General Internal Medicine. I'm a primary care doc that loves to scale care, and I've been working in population health informatics now for a good 10 years. Delighted to be here. Thank you, Mark.
Thank you. Jun Lee, if you would like to go next, please.
Sure, I'm Jun Lee, and I have 20 plus years of healthcare management experience, 15 plus years on large scale operations and population health value-based care. Currently, I'm the Chief Population Health Officer for Palomar Health in San Diego. And prior to joining Palomar, I was the Chief Population Health Officer for a large MSO IPA group that oversaw 1.2 million lives. So I've had a pretty good run in terms of kind of soup to nuts, building out data platforms and seeing it being used to help our populations. So happy to be here.
Thank you so much. Josh Coram.
Hi, I'm Josh Coram, Chief Data Officer for Rady Children's Hospital here in San Diego. And the part of my teams, the enterprise analytics and data engineering teams are big partners in what the folks in population health do here at Rady Children's. So we work intimately together, not only with that group, but then the general EMR teams, helping leverage data and delivering even better and better care with what we do every day.
Wonderful, thank you. Andrea Snyder, welcome.
Thank you. Good morning. My name is Andrea Snyder. I'm the Vice President of Health Services here at Sharp-Reese-Daly Medical Group in San Diego, a large multi-specialty medical group that's part of the larger Sharp healthcare system. And I have over 20 years experience in quality and patient safety. That was my first love. And then I had the opportunity 3 years ago to join the team here at Sharp-Reese-Daly, working on population health, quality, utilization management, the data team, and other supporting services. I'm glad to be here.
Thank you so much, Andrea. So I'm going to, before we get into the substantive element of our interactive discussion, I am going to ask each panelist to just spend 2 minutes talking about what they and their team are doing that's most pertinent to our discussion right now in terms of leveraging analytics for pop health. I think I'll just go around the circle again. And if everyone just could take just 2 minutes and kind of summarize that so we understand what people are working on. So Dr. Sida Patel?
Well, hi, yes, thank you. So I guess when we think about population health, I'd like to break it maybe into 3 segments. So I think there's core infrastructure. We've been working on making more than 150 registries that help us really understand different cohorts of patients, whether they are relevant to a payer or whether a chronic disease or whether a type of utilization. And so these are niche areas and ways to really design the infrastructure for the workflows to take care of our patients. So we have this sort of core that kind of feels that direction. And that allows us to have care management, risk scoring, all kind of things behind that. So that's definitely been good fun. What's new in the space is working really in the surgical spaces. I think we thought about bundled joints and how to actually get our patients with those sort of things, but now we're moving into other niche areas like emergent general surgery and other things, and how to harmonize standard work so we have better outcomes for our patients. So that's like the first part, is like that core infrastructure. The next thing I kind of think about is really care management teams. And sometimes this is sort of standard primary and secondary prevention. Did you get your colon cancer screening? Did you get your breast cancer screening? And we always seem to be running some new campaign and some new standard reliable work to get our patients activated for their care for that standard reliable work. And also to dovetail right behind that, care management. And the care management teams are usually the same core teams doing that outreach at scale, but now they have specialized teams as well that deliver that RN case management, the social work, and all of that. So again, that's the second piece, is really scaling the people around populations, is really sort of thinking about care management teams, patient navigators, social workers, and sort of delivering population health in the new modern way that it's delivered. And then I think there's a third place that feels maybe a little uncomfortable to at least me and some of us, but it's thinking outside of our walls. So who are our partners and how do we bring them closer with this? This could be community-based organizations. This can be scaling with national collaboratives, but how are we actually thinking about integrating our data with other data outside of our walls to make a community-based care that's different? And I think that's kind of a new uncomfortable space. There's lots of little startup projects here, but it's really about understanding the health of a patient really isn't at the center of a medical center or a health system. The health really starts with the patient in their home, in their community, and who are we partnering there and how are we delivering that? So lots of good work in all three of these spaces. Thanks for asking, Mark.
Wonderful. Great summary. Thank you, Doctor. June, I'm sure you're working on a whole bunch of different things at Palomar.
Yeah, so thanks, Mark. Similar to what Dr. Sida Patel was mentioning, we're doing this similar items in terms of characterizing our patient population. I think it's a very important piece to understand the complexity, what chronic conditions they may have, and the work that goes into that, just as a basic. And then how do we accomplish the quality outcomes? How do we make sure that breast cancer screening is happening with the population? How do we identify those that have hypertension, and how do we manage that component for them? And all those predictive measures, or all the measures, the preventative measures that we're looking to accomplish. And I think wrapped around that is, how do we get that information in a complete, accurate, and timely way back to the providers and the teams so that we can streamline the operations from a pop health standpoint. And we're not being clunky and kind of having repeats or missing information. To me, that's a big part of our challenge and what we can do better. We are looking at some innovations and technology and helping us with that. And we're excited about how that can be. And as Dr. Sida Patel had mentioned also, is going beyond our walls. So if we look at kind of a home visit standpoint, how do we leverage technology to get information to the providers that are doing these home visits? How do we get them to accurately capture the information, and how do we bring it back, ingest it, and then use it to better manage that population? And then I think in terms of long-term down the road, a more advanced, as we get to more advanced stages, it's really going to be utilizing the data in more of a predictive analytic way. So that way we can get to the point where actually anticipating and trying to determine what patient behavior looks like, and how do we then actually prevent costly episodes from happening and keep the patient as healthy as possible. So there's this big spectrum, and we're probably more at the basic levels, moving toward intermediate, and then hopefully at some stage down the road, getting to that more advanced stage of taking care of our members.
Terrific. Thank you so much. Josh, enlighten us, especially since you're working in a pediatric context.
Yeah, definitely. Thanks for the opportunity to share, Mark. Much like Dr. Sida Patel shared, we leverage similar tools from Epic. That I think that's a great description. Foundational work, the registries we've had in place for years, and really beefing those up, enhancing the workflows that are around those. For example, asthma, to keep enhancing the care and making sure all kids are on an asthma action plan, being able to track that closely and characterize and understand what's going on with that population. So that's a very similar, again, to what Dr. Sida Patel shared as far as foundational stuff that we're doing. And then I think key areas where we're actually working on some new and interesting things are in two areas, behavioral health and then emergency medicine, which a lot of folks don't often think of emergency medicine and population health. But that'll be an interesting one I'll share in just a sec. But for behavioral health, we have been modifying our workflows and how we are engaging in behavioral health care for our children and embedding it in primary care offices, for example, so that we have workflows that we're putting in place screenings for everybody that's coming in an outpatient context, and being able to identify those that are at risk for depression or suicidality, and having a warm handoff embedded in our offices and being able to tailor the workflows to that. And then on top of that, building around all the analytics within that, so that we can capture these kids, that very rich screening data that we have, and also pairing that with, because of our full spectrum of care, we not only have, outpatient, primary care and the behavioral health that we're having there, but also inpatient psychiatry and one of its first of its kind emergency psychiatric ED. So we can bring all that together and better characterize the patients that we're seeing in the behavioral health space. And we're also starting to bring in census data, socioeconomic health data, to find out differences and characterize our population, to be able to better target different interventions for populations based on those demographics. So really interesting stuff and evolutions happening in that program. And then going back to the emergency medicine space, for a long time we were industry leading as far as our average left without being seen under 1%. Really doing a phenomenal job taking care of all the patients that came in our door. And then when COVID hit, our volumes fell off a cliff like everybody else. And in the last 6 months or so, they have just skyrocketed back up to the point where this summer we've had our highest summer volumes ever in our emergency department. And so it's the great latest thing that we're working on is they came to our team and said, we need to figure out the population that's coming to see us and why they're leaving and when. And so that's where we've built a really awesome analytical tool to help characterize, time of day that they're coming from, zip codes that they're coming from, the acuity, based on all those characteristics as well, and the types of lab and rad that they're getting done, and the wait times at which different points that they're coming in. So it's really giving some amazing tools to our clinicians and operations folks to better understand the populations that are coming and seeking care, and being able to tailor how we're caring. So as many have said, we're trying to meet them where they're at when they're coming through our doors, and really enhance the care that they need when they come to us.
Terrific. Thank you so much, Josh. Andrea, I know that you are very, very, very advanced at Sharp Reese Staley. No pressure, but I know you're doing some really amazing things. So go ahead, please, and share a little bit.
Yeah, so, I echo a lot of what's already been said. I think that we are pretty good at identifying our patients that are high risk, but really what we're always continuing to try to innovate are identifying those patients that are emerging risk, and understanding what are those risk factors that maybe we haven't thought of. How do we leverage predictive modeling to better identify those patients and weave in some of those additional data points that maybe we haven't looked at as thoroughly in the past, like social determinants of health were mentioned, pulling those in. The other place that we're really trying to innovate is in remote patient monitoring. And while we've been doing that for a long time, I think that really is where we need to go to keep our tabs on those patients and understand what's going on outside of their visits with their clinicians, and then make that data manageable for the providers. And I think for us right now, the focus is actually on sort of buffering all of that information with our case managers and making sure that we're only presenting the patients where we really think there's a need to intervene to the primary care physician, so that they're not inundated with all of that information. So I think that those are probably the key things that I would add on to what's already been said.
That's great. I love that term, buffering. In the first second when you said it, I thought you said suffering. There is suffering in using data, but you're all going to be saints soon. But yes, I think that's a wonderful term. I want to talk about policy, but I realized I really do want to talk about challenges first. And I want to contextualize this because all of you are very advanced. You really are. You're doing amazing work on the leading edge. Many in our audience. I mean, the one advantage of our out of necessity taking this program virtual is that many more people from across the country will see this. And you are all in advanced organizations, and San Diego is an advanced market in many ways. Many of the things that you've just all mentioned are really still dreams for some people in other parts of the country. That said, since you're ahead of them, what are the biggest challenges right now that you're facing? They can be people, process, technological, clinical, policy, anything. What are the biggest challenges and how are you addressing those challenges? And it's all a journey. We know nothing is ever finished, but who would like to jump in and talk about challenges that you're facing?
If nobody wants to go first, I can jump in. I think one of the biggest problems I've seen year after year for quite some time is people. And it's only getting harder in this space because I think it takes a certain aptitude, right, of critical thinking and really understanding what's possible in the world. I think more and more population health really is focusing on analytics, right, because it's being able to manage the data and make sense of the data and serve it up in a way that's effective, that can elicit action at the right time. And I think the folks that actually have the skill set to comprehend the data and know how to best partner with the folks are very, very hard to find. And the fact that they're few and far between is only made worse because it is a skill set that can be leveraged by many industries, and many industries are wanting to leverage talent in this space. And the unfortunate thing is, for example, we can't pay as much as the finance and the tech and communication sector. And so, we rely upon those that are talented and mission driven, and want to make good things happen in the world in this space. But the thing is, we really need to increase the pipeline of folks coming through with this skill set and the talent base, because there really just aren't enough to come around. I just hired somebody on my team, and we were searching for more than 6 months before we could get a hit for somebody that we could afford and wanted to work for us. And that's even harder for us because in the healthcare industry, we have a challenge competing, being a not-for-profit children's hospital. We don't have the biggest bottom line, and so even there, we're not in the top of the food chain in our industry, and our industry being towards the bottom. So that's the biggest thing, day in, day out. There are a lot of challenges I think we all face, but that's the biggest one that I think is hitting us in the stomach, if you will.
Yeah, let's drill down a little bit because everyone else nodded when Josh said that. So one of the things that we're hearing is exactly what you just shared, Josh. Healthcare cannot afford to pay the highest rates, and you're in a nationwide battle or a nationwide competition to get really good people. You're competing with other industries, you're competing with other entities within healthcare, and then I'll add a layer, which I'm sure you're experiencing too, that what kinds of people are you folks all looking at? I keep hearing the classic, should we bring someone from healthcare who perhaps is a clinical informaticist, perhaps a nurse informaticist, for example, or do we need like a hardcore data scientist who is like super incredible in that area, and then we teach them about healthcare? And I've never gotten a settled answer. I've gotten, yes, Dr. Sida Patel, tell us how you answer that.
Yeah, well, so first of all, what you want is a Swiss Army knife. And I'll just say that. And, you aren't going to find them, you're going to make it. So we're all making Swiss Army knives at our personal health factories here. And it's good fun. So the best thing is always having good people. They share your culture. They have great human interaction, and then they're clever. Right. And then how you assemble the team is you have actually basically a collection of Swiss Army knives, if you can imagine, is the best population health when we're talking about the tech infrastructure. And so you want to kind of look for people that I think have different talents, because, some of us need a librarian on the team to keep track of all the different terminologies and things. Some of us need like an innovator that's going to sort of, take the jump and do the skydive with us. They're going to challenge us to do something different with some guardrails. So we're looking for different interpersonal characteristics, different technical characteristics, and then we're actually building the Swiss Army knife with the people. So then the biggest challenge we have is if we lose the talent that we nurture over time, I would say. That is definitely a big risk. But also we're contributing to the landscape. If I develop someone and let's say that they find a career opportunity with Andrea, right? That's actually great for the person that's been developed. So I think it's okay. We're all working together in this. I think of it also as the lens of an academic medical center, and I teach in the School of Medicine. I was just teaching last week clinical informatics. I think the reality is that the depth that you need in this space is really incredible to be phenomenal at it. I can teach a clinical informatics postdoc for a year, and I feel like they're kind of in the beginning of understanding how to scale data. So it's a very deep space, and we probably don't have enough people that really get the practical knowledge plus the technical background. And, we can't mature everybody for 10 years and then have them on the bench ready to go.
Yeah, exactly. Andrea, I know you're nodding a lot.
Yeah, I think I love the Swiss Army knife. We call them unicorns. You're looking for someone with that entire skill set, and they don't have it. They just, unicorns aren't out there. And so I agree that we have to build them from within. We actually have here at Sharp Healthcare at the system level, we have a council of analytic leaders who are working on standardizing, because we recognize that these, data professionals, analysts, scientists, we call them many different things, that they exist across our entities, and that we need to actually look at standardizing, and this sounds mundane, but job descriptions and the training and how they're oriented in the curriculum, and then build them up to meet the different needs. I loved Amy's description of who she's looking for. I think resourceful goes along with being clever. We're looking for those team members that are willing to jump in and try to solve different problems. The other thing I was going to say about people, just beyond the data scientist world, is that people is a challenge across the board. And so I actually think that our current staffing environment, in the clinic settings, is a problem, and it leads to instability in our processes. And my fear is that that's not going to be over soon. So we're looking for ways to leverage technology and hardwire our processes so that our patients' experience is consistent. They're getting the same level of care and service, regardless of who is staffing that clinic for that day. And I think that relies heavily on teeing up the right data for the staff and the physicians to have the information they need in front of them to provide that reliable experience. So I think it goes beyond just the analyst teams, but it's a challenge across the board.
June, I'm sure a lot of this resonates with you.
Yeah, it does, and just kind of going down that thread, the one other example, I built out a population health platform. And one of the challenges, going back to the question of, do you bring in the expertise, or do you bring in someone that has the healthcare knowledge and blend it? And I will say that definitely the term of Swiss Army knife, unicorn, they all apply. There was a period where one of the organizations I was working with had the philosophy of, look, the technical expertise is much greater than healthcare. We can teach healthcare. But then I was spending time explaining to someone what a PMPM was, and getting down to some real basics. And I think the challenge there is not that we can't teach, and to Dr. Sida Patel's point is, we will continue to contribute to the resources that have more knowledge and advancement of pop health, and that'll add to the pool, which I think is great. But the challenge also becomes, from a pop health standpoint, it really is about limited time, limited resources, and limited funding. So that all plays a part in how do you develop this? How do you continue to kind of raise the tide so kind of all the boats lift, and do it in a way that you feel like you're running and not always two steps forward and three steps forward and two steps back, because a lot of times that's how it feels. So I don't have a solution. I think we're talking about challenges. I think the other challenge ends up being is, and I was out in New Mexico running operations there, and the dynamics of pop health and managed care was more in its fledgling state. So having the balance between more of a fee for service mindset and versus managed care and pop health and value-based care, that's a different challenge. So as we look at the spectrum across the country, they're going to have different experiences. And one of the challenges that we had, and I think this is predominant when you shift from kind of that fee for service mentality where you're getting paid to do to a let's build and let's grow and let's build the infrastructure. And one of the fundamental challenges, I think, is there is not a great pathway for funding that build or funding this, kind of that startup of pop health or to continue to nurture it. It ends up being you're getting paid to do and manage and as if you're in a more intermediate or stable state. And I think that becomes a tough lever. There's a lot of organizations that end up being in between where they want to do it, but they don't have the resources to do it, the know-how to do it, or the funding to do it. So that's another layer of complexity and challenge that I think that presents itself today.
Yeah. What that leads to, I wanted to ask about the policy landscape. Are there things that could help all of you on the policy level in terms of maybe funding or the ways in which stakeholders, purchasers, payers, consumers use data? One of the great things you do have in California is that 20 years ago, the major health plans all said, all right, we're going to push towards a unified set of quality measures from providers so that you're not, doing 10 sets of quality measures, which was driving everyone crazy. I know the physician groups were really, really exercised by what was going on. So there's that, CMS and CMMI did this fascinating webinar last Wednesday that I attended for the press. And it was Administrator Chiquita Brooks-LaSure and CMMI Director Liz Fowler. And they were talking about how they're really going to try to make all alternative payment models, including ACOs, more rationalized so that the development of data for example, the MSSP won't be as difficult for providers. Is there anything that policy leaders can do to help out here? Because a lot of you are expending a tremendous amount of time and energy trying to figure out how to collect data in ways that please purchasers and payers, right? I know, Andrea, you are. Oh, and Dr. Sida Patel, you wanted to say something. Go ahead.
Well, I think about, I have in my portfolio, I have more than 100 quality measures, and not all quality measures are the same. I think that some of our HEDIS specifications are great, but there's not also agility. So as we scaled telemedicine, all of us suffered from not having HEDIS measures that incorporated new care delivery systems, and the life cycle for HEDIS and NCQA has to be shortened to accommodate innovation in our care delivery. I think that would be super helpful. I think also not all measures are really appropriate. So I think as we think about sort of the true EHR and the ecosystem of data, how do we design new measures that are appropriate for that? So for instance, if you have a contraceptive care measure, but it assumes that the person is coming in for family planning, AKA sexually active, the denominator inclusion criteria may not actually be correct for scaling against a population of perhaps a person that's in a group home who's not sexually active, who has an underlying medical condition. There are assumptions that sort of these measures make, and they're not, again, appropriate sometimes for the denominator or thought out and vetted at scale to hold accountability. So I really think that there's good work to do at a policy level nationally to actually have better EHR-based quality measures that actually get validated against real cohorts. So I can't wait for that to happen. It tightens the informatics. Then we can really tightly put the incentive dollars to us. Right now, there's always sort of nuances in how it all falls apart. So that's really a big thing. And then when I think of it from a primary care doc lens, I mean, it's pains me to see how much we're disincentivizing patients between shared cost to come into the office. So what's happening is, like, a patient yesterday, I found out stage 4 lung cancer, right? I mean, these are things we don't want to happen, right? Why is the patient not showing up? Well, the copay is there. And will the patient maybe hope the symptoms get better and maybe be worried about shared costs? So we have to be very careful in primary and secondary prevention, given that only 10% of cost is really with the physician who has those face-to-face encounters and lots of free care in between. We're now getting less and less face-to-face and more free care, but it's really just not sustainable. And we got to see the patient in the office sometimes. So I think that's a great policy question. Like, how do we, scale population health, but not disincentivize patients for routine screening and care that really identifies early detection, which is better for patient outcomes and better for cost.
Absolutely. Who would like to add to that?
I'll jump in. So I think the other part that I think is a challenge and I think can be much, can help population health quite a bit is around just sharing of data. So all systems, if there was this universal ability to share data, it would make life a ton easier. And then I think around data, the other part of it would need to be about timing of data. So one of the challenges that frequently happens is if you rely on health plan to give you feedback on your population, it takes about 3+ months. So they see the provider sees the patient, it gets entered into our system, it goes to the health plan, and by the time the health plan credits and lets you know that the patient came in and had that breast cancer screening, that's been 3+ months. And it's delayed, and that delay creates, and then you multiply the delay by every single measure, every single patient. And then if you have different initiatives, let's say whether it's a provider within the system seeing the patient in the office, or if it's telehealth, or if it's at a home visit, that sharing of information is not as streamlined as possible. The timing of the information is not as great as possible. So I think there's things that we can look at to accelerate that. The other thing that I'll share, which is a little bit of a soapbox item, but on the chronic condition HCC capture, it resets to 0 every year. And this part baffles my mind because we talk about physician burnout, we talk about how do we make the system more efficient. And if it's, I get that the chronic condition, if theoretically, if it's a chronic condition, and yes, there may be certain things that drop off, but why not have it be that you identify the drop off versus start at 0 and then build back up every single year? Because if it's about patient care, we need to focus in on how to keep that patient healthier. How do we manage that patient for that chronic condition versus what feels like more of a paper documentation exercise and in some ways kind of jumping through hoops. So to me, that's a better way to kind of build and utilize physician time. And then I would look at telehealth. I know that there's been a lot of advancements in telehealth. And if we look at kind of the policy pieces, initially it came out around chronic condition capture. And this again is a little bit of a opinion piece, but the aspect of it being an audio video component and the need for it to be audio video versus, let's say, a phone visit. And I think that there's an aspect of capability versus actually doing the work and what's really needed. So I think that that's an area that's really important. And as we look to leverage that further, how do we do it in a way that makes sense for patient care and managing population? And the final thing I'll go back to is, as we talk about these items, some of this is new and some of it needs to be built and some of that needs to be invested in. So how do we create funding around it versus here you did the work and you get credit for doing the work, but all the infrastructure and the layering and the building is not supported in the system today.
Yeah. Josh and Andrea, do you have anything to add on the policy front?
I think I would add just a couple of quick points on the great points already made. And I think building upon Dr. Sida Patel's comments, I think, from a policy perspective, another thing that would be assistive is, all the regulatory reporting that we have to do, streamlining that so that it's not, multiple overlapping, same pieces of information calculated slightly differently, at different times with different time periods. It's a lot of what people ask for is pretty much the same thing, yet we still have to tailor and customize the data responses to each one that they come. And if all the government, regulatory agencies could really streamline their ask of us, that same machinery that we use to accomplish that, we could devote more to population health and better serving up the analytical needs in that space. And then the other thing I would add, building upon June's point, with respect to data exchange, I think what I would like to see from a policy perspective, and I think many others would, is access to, or creating the infrastructure to give us access to other information other than healthcare, so that we can leverage that, because that's what we're learning right in our space here, and particularly population health. There is so much more that influences outcome than just what healthcare and whether or not you got it right. It's those factors that influence, whether or not that care is going to be effective for you. And a great example, that would assist us in the pediatric space is actually getting our hands on school data, right? Whether or not somebody attended school, how many, absences they've had at different times. That is a gold mine of information, because it is indicative of, complications in their health. That is often a canary in the coal mine that we learn about after the fact, after it's self-reported. You see the correlations in the data. Just an example. Again, but having insight into things like food insecurity and other stuff like that would be tremendously impactful in improving the care to populations that we serve. So policy-wise, if they could start to, have some support for creating infrastructure to give healthcare providers access into that kind of core critical information, which many people don't consider, historically healthcare data, but would definitely influence health outcomes.
Yeah. Andrea, do you have any thoughts?
Yeah, great points have been made. Wholeheartedly agree with the wastes caused by the data delays and having imperfect data, as well as the HCCs. But on the topic of physician burnout, we are somewhat a victim of our own success in getting our patients really engaged in using our bi-directional patient portal. And kind of the flip side of what Amy was talking about in terms of incentivizing patients to come in for their care, some of which because of the pandemic have delayed care, which is really concerning. We have to have access, right, to get our patients in to see their physicians. And one of the ways that we've been able to improve access is to meet patients' needs, in their home and in that asynchronous method through the bidirectional patient portal. Now, for our capitated populations, we have a financial buffer to provide the care outside of the visit, but really being able to incentivize physicians to meet patients' needs outside of the visit, I think is really a critical step to take so that we can get their care needs met when they need them and not worry about, well, I need you to come in for a visit so I can charge you for that, and removing some of the barriers to making that care accessible where the patients are.
Exactly. So we have just a little bit of time. I'm going to ask each of you, what does the landscape look like for the next few years for your organization and how you see the healthcare system in general moving forward in this? And let's start with that. What does the landscape look around leveraging data analytics for PAP health in the next few years? Who would like to share thoughts? There's no future? I'm sure
I can go.
Okay, thank you, Doctor.
Okay, of course. So I think we talked about just being a little more clever with all the different types of data that we're using, I see us actually moving outside of thinking about a patient with an illness in sort of a bubble and moving beyond the even social determinants of health. So Josh was talking about, standard reliable processes for depression screening for every patient, right?
Yeah.
Making sure that that happens with intervention. But now we're talking about, hey, what about the landscape that they're in? So one of the innovations we're working in is thinking about the Healthy Places Index, thinking about the social deprivation, which means, does your community have the things that you need to be healthful? And so we now map that for every single patient. And then what we do in that landscape is actually risk stratify, sort of take the patients with the least health in their community. And when we're doing outreach for hypertension, for instance, to address an anti-racism tactic, think about for Black and African Americans that disproportionately have poor cardiovascular outcomes. Now look at the communities that they live in and make available a better assessment for access to healthy, low salt cardiovascular meals. So that's kind of like, wow, like supersizing in a whole different way. So we're really trying to get much more niche-y. And I think the landscape is more about thinking about what the patient needs in their space, partnering with the community-based organizations so that we can extend health from the lens of what we know at the core with their medical conditions now with partners in their community to better deliver that care. So I think it's super, super exciting stuff. And we see this again as really thinking about health equity, thinking about really an anti-racism stance that's very firm. In San Diego, I can say at UC San Diego Health, half of individuals who are blind would identify as Latinx. It's just wrong. We only care for about 20% of our population would identify as Latinx. So why would it be that half of the patients that we see who have blindness from diabetes are Latinx? We have to do something different. And all of us say, no, 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 we screen every diabetic, we reach out, we campaign, we do telephonic, we do text, we do this, we do that. It's linguistically inclusive. But at the end of the day, the patient wasn't screened. And we all know that the patient with the A1C of 12 can hardly read, has 3, barriers to care at least that are structural in nature. We gotta bring the screening right up to them and early identification and avert blindness. So these are the exciting things in the horizon over the next 5 years, is to kind of have these never events that we just got used to seeing in healthcare, really in the prevention space, become something we're really trying to tackle.
I appreciate that tremendously, Doctor. I especially appreciate the health equity and racial and social justice lens. I'm very aware, actually, the Latinx population, you've got such cultural issues to face. There's a reason why, and it's sometimes people think it's purely linguistic. The barrier is purely linguistic. It's not. That's a piece of it. But there's a huge cultural, we're making inroads in African American communities where historically diabetes was simply socially accepted as a thing, right? And so you have to help the communities overcome that perception that it's, if very elderly Black people, they grew up at a time when the communities would just say, oh, you have the sugars, and that was it. And there wasn't, and because of lack of access to healthcare, sometimes that fatalism was accepted socially. So I appreciate very much what you just said. Others, what will happen in the next couple of years?
I think building upon what Dr. Sida Patel said in your comments as well, Mark, I do think we have some interesting things on the horizon, especially here on that note in the San Diego space, because I think, I think we're all fortunate to work in this community. It really is a great little ecosystem for many reasons. And I think in particular, seeing where things go in the next few years, I think, seeing many organizations are using, predictive analytics, right? It's still, you hear a lot of flash and sizzle, right? But there's still only a very little effective of that stuff going on. And some of the most effective things you're seeing are like in the sepsis use case where, we do have good data in the inpatient environment, pulling, vitals information, on a real-time basis and be able to interpret that and predict deterioration before it actually happens and intervene earlier. I think there's a lot of good proven use cases going on with that. And so I think that's laying the groundwork to be able to develop more effective, use cases, especially as we extrapolate out to the outpatient environment, like Dr. Sida Patel was referring to. And again, I think that's interesting in San Diego because a lot of what that will entails a lot of those demographic factors like we're talking about. And San Diego really is this rich area where you have those rich demographics where, because as we all know in the data world, right, you need good, rich data. It can't be monolithic. It's got to be, you have to have a whole mix so that you can, test your data sets and your models very effectively and have all the correct permutations. And I think that's the great thing about San Diego is we do have a very rich ethnic makeup and, a good mix up of socioeconomic so that, you really can get a good cross-sectional analysis using that data. So I think we are on the precipice of being able to do some really great things using that data that we have available to us. And, I think one of our aspirational things on the Rady side of the house, looking at, behavioral health, like we were talking about, right? We have, California is one of the most at risk, right? Based on the data across the country, as far as adolescence and suicidality. And San Diego is not great as far as all the counties in the state, as far as that ranks. And we have an opportunity to improve things here. And what we know, one of the statistics are about half of kids come into the health system in the month before they attempt suicide. And, I think one of the fascinating things is we have the potential to identify the half that don't come in based on their data, right? Because they have been in our system before, because Rady sees 90% of all the kids in this community at some point or another, they've been in here. And so that's an interesting challenge for us in this new space on the frontiers before they come into our door. That they haven't been here, but they're at those risks, that they're the ones that are not going to come in before they attempt suicide. Can we find them? Can we find them ahead of time, and can we intervene? I think these are the kind of exciting things that really, we can really start to sink our teeth into and start to move the needle. Because it really feels like we're getting at an inflection point. We've been, putting all these resources in to get all this information, and now we're getting ready to actually use it in more and more effective ways. So I think it is really exciting times along the lines of what a lot of Dr. Sida Patel spoke to.
Wonderful. We're a little bit running out of time here. We just have enough time for everyone to give our audience one piece of advice. And I know you have it in you. I know you're all wonderful experts with thoughts. If you could leave one piece of advice for our audience based on everything that we discussed this morning, what would that be? And who would like to go first?
I'll go first. I think you have to keep it simple. At the end of the day, all the data that we create and report and have beautiful Tableau dashboards for, if you can't put meaningful and actionable data in the hands of the provider that can make a difference in that patient's life, then it's all for naught. And so I think not to be intimidated by the level of sophistication. Today, it's about giving a physician a list of patients that he needs to go after, or a case manager needs to call and check in on. And so I think sometimes you have to just keep it simple and not overthink it.
Dr. Sida Patel, I can see you have it right on your forehead.
Don't fall for it. So I think, we could buy 100 apps. We could, think about the new Smart on Fire. Don't fall for it. Be strategic, have goals, and think about where you're going, and then be really selective about the vendors and applications and tools that you bring in. And you can get there over time, because it's really about the people. It's not just the technology. Of course, working with, other good, companies, wonderful. But again, you don't need 100 different types of sort of applications and companies. You need a great strategy and good goals.
Wonderful. June, would you like to share a piece of advice?
Yeah, I'd love to. So I think along a similar thread is to be purposeful and understand the spirit of what you're doing and be very intentional. Because I think if you surround yourself with that core, you'll actually get to that spot of what you're doing, and knowing that it builds toward that greater purpose, and there's meaning it becomes meaningful what we're doing. So that's what I would share.
Wonderful, thank you. And Josh?
Great advice already given. And I think the only thing I could think of to add to that, to build upon that is, as many already indicated, I think, to move the needle on this, you'll need to partner with key folks and be very strategic, but to bring the rest along. I think I go back to what did that come out? The 90s movie, the adage, build it and they will come. So partner with those key folks and believe in that strategy and that vision you've developed, and the rest will come along, and then you'll be able to move that needle. So it takes a bit of that visionary spirit, but as well as conviction as well to stick with it and know that once you've created that, have faith in it.
I appreciate that very much. Well, one of the great things is that all of you are very strategic, you're very thoughtful, and obviously you're very smart. So at least these initiatives are in good hands in your organizations, and I'm sure they are in other organizations as well. So I'll just leave us with a quote. This is one of my favorite quotes. I end some of our sessions with this. 2,000 years ago, the Roman orator and senator Seneca said, "Those willing to change the fates guide, those unwilling they drag." I know none of you will be dragged, but being dragged is very unpleasant. So the great thing is those who are willing to lead in healthcare will really do well in the end through all this complexity. And I think that one of the things that's very clear in this discussion is that leadership is a big element in all of this, and you're all leaders. And I can see that you and your colleagues have made a commitment to move forward, to leverage data for the most important purposes, including the health of your communities. So I just want to thank you all very much. This has been such a great discussion. You've all been wonderful. And I can tell you're all great Swiss Army knives. So may the Swiss Army knives move forward. So thank you all again very much, and I hope you have a great day. And thank you very much to our audience for participating.
Thank you very much, Mark.
Yeah.
Thank you.